Sorry, give me just 1 second. All right. So Sheree and Jen are going to be joining us shortly and giving an overview on the Accountable Health Communities program. So instead of having them present first, I'm going to start with this month's brief check-ins. All right. Okay. So first topic for today, quality assurance. So QA has officially started back up this month. And I spoke to Stan to get kind of an idea of what's happening, what he's hearing, and he's got some good things to report. So he said that overall, everybody's been doing a great job with building a dialogue with our callers, and said that overall we sound really confident and professional. So hooray for that. Starting on a positive note, kudos to everyone.
Yeah, I was wondering why that was blinking.
Okay.
No. Well, now I am.
Cam, can you mute yourself? And everybody else, can you mute yourself?
Yes, absolutely.
Everybody too, can you make sure that you're muted unless you have something to add? Okay. So last month I had mentioned that there were going to be some changes with the supervisor line to make it a little bit more efficient. I think everybody knows that, there are times when it can take a really, really long time for someone to answer because calls were rolling from phone to phone to phone to phone. So we have made some changes to how that supervisor line flows. And so instead of your call rolling from Chris to Aaron or Aaron to Chris and then to Sheree and then to Diane, all the calls are going to ring or are ringing to Chris, Aaron, and Sheree all at the same time. And then if none of them answers, then the call will roll to Diane. So it's going to ring to Chris, Aaron, and Sheree 6 times. And then it's going to roll to Diane. And once the call rolls to Diane, you're going to hear 4 rings, and then you'll receive the voicemail option. And then just a reminder, please don't call the supervisor line multiple times in a row. If nobody answers, then nobody's currently available. So if that's the case, just leave a voicemail on Diane's phone, and then someone will be getting back with you shortly. And then just remember, in instances of tardies or any call-offs, you're going to be considered a no-call, no-show if you don't leave that message. So you don't have to talk to a live person. If it rings to Diane's voicemail, just leave a message that you're going to be late or that you need to call off for whatever reason. Okay. So next, Nikki had asked that I do some reminders regarding coordinated access. So first, remember to make all coordinated access referrals incomplete to Nikki when you do have a CA referral. Some staff members have made an incomplete call to themselves or to a different staff member. So just be aware to make sure you're saving to Nikki. As long as you're in the Lucas County Access site, she should be the first person that comes up on that incomplete list. So we tried to make it easy for her to for you to find her there. Then next, remember to use the after hours process after 4:30 p.m. Monday through Friday, and then also on weekends and holidays for families with children, as as it's stated in refer. So just a refresher, you want, if you've got somebody calling after hours and they have children and you're not able to divert them, then you want to call the supervisor line. Okay. When you're determining whether or not to,
Molly?
Yes.
Molly, can I ask a question? Because I'm confused there. I have been telling people if they with children, if they call before a time that they could get down to the Cosgrove.
No, this is no, Judy.
This is for
Lucas County.
I'm sorry.
Yeah,
I'm sorry.
yeah.
Thank you.
Yeah. Different process. Okay, so when you're determining whether or not you should use that after-hours process, make sure that you're asking that person some questions to see if they can make arrangements for themselves until coordinated access opens back up. So like some suggested questions would be, are you able to stay where you are tonight? Or where did you sleep last night? Can you continue to stay there? Is there any friend or relative that you can stay with just until we can get you connected to coordinated access? So be sure to ask some of those questions because you know, Nikki and Sandra have to take those after hours calls, and sometimes they're very late at night, and we just want to make sure we do our due diligence so that we don't have to interrupt their sleep too often. Okay, don't forget to complete all the data points on page 3 and refer. If you're not filling those out, when you save an incomplete, it's not going to remind you to fill those out. So you have to just be mindful that that's something that you'll have to complete. Otherwise, then that responsibility rests on Nikki and Sandra. Remember to save a referral to Emergency Shelter Clearinghouse. And then if any outside shelters or any other resources are needed, then don't forget to make those referrals as well. And then use the incomplete notes. So it's really helpful if you can provide a little bit of detail about the person's situation in there, and that helps them to prioritize who they're calling back first. Okay. All right. MedRefer. So Christy is eagerly awaiting more client referrals to the MedRefer program. So just a reminder, when you're assessing Cuyahoga County residents' income needs and expenses, to ask that prescription question that we have in Refer. And then also keep in mind that the extra assistance that Christy provides is solely for accessing prescription medication. So she doesn't have any additional resources for durable medical equipment, and she's not able to provide any sort of help with navigating insurance plans. If somebody needs assistance with navigating insurance plans, there are some options in some other organizations in Refer that can meet that need. So depending on what kind of insurance that they have, if they're looking for Medicare supplemental programs, there's some organizations in there. OSHIP, of course, is at in the front of my mind on that. There's places that will help with navigating the marketplace, and then also the Medicaid helpline can help people with choosing a Medicaid HMO. So just be sure for those types of questions to refer them to those agencies that are able to assist with that. Okay, and I have a few notes here from Todd. If you notice that you are the only one logged into InContact during an evening or a weekend shift, you can go to the schedule viewer in IEX to see if anybody else should be working. So if somebody is scheduled to work and it's more than 15 minutes past their shift start time, please call the supervisor line. And if you're scheduled to take a break and the other person still hasn't logged in, then don't take a break. So I've got some screenshots here for you. You can see who else is working the same day as you by clicking on the schedule viewer and then by clicking on schedule start to arrange the shifts by start time. So you can see an example here for this coming Saturday. Sometimes it might look like somebody is scheduled to work, but their shift has actually been canceled due to some type of time off. And the only way to verify whether someone is actually scheduled to work is by opening up the daily viewer, the D in the details column to the left, to see what kind of activities are scheduled. And if it shows open, then that means that they should be working. So back to this over here in the details is what that's referring to. You'd click the D for details. And then this is an example of what it would look like if someone is scheduled to be on a shift. If it shows time off, then they're not working. And if you weren't already made aware of the fact that you're working alone, then it's worth contacting the supervisor line because it could be a scheduling error that they are not aware of. If you weren't already made aware of the fact that you're working alone by a sorry about that. I double copied that. Okay, and then also just consider the time of day before calling the supervisor line. So if you're working alone because someone else called off and it's between the hours of 12 a.m. and 7 a.m., then there's probably nobody else available to work with you, and you'd probably be able to handle that call volume on your own. Okay, so this is just a screenshot showing details, schedule, and then by opening it up, you see here, this is unpaid time off. Okay, I wanted to talk a little bit about referring to churches. Some of the researchers have reported that they've had a few churches call and complain that 211 referred people to them for services that they don't provide. And I just wanted to remind everybody that if refer does not reflect that a church or any other agency provides the service that the person needs, then don't refer them there. We understand that it can be difficult to tell somebody no, but it's really better to be honest rather than to make that person run around and calling every church in their neighborhood, because it's frustrating both to the caller and it's also frustrating to the churches that have to keep telling people that they don't have the funds to help them. And then also it puts a strain on our relationship with the churches. So is it ever appropriate? If you have a caller with unmet needs and you're troubleshooting with them, instead of suggesting that they try a bunch of churches, ask them if they belong to any organization where they may reach out to other members for help. And so this kind of broadens it. So when you're talking about an organization that they might belong to, that could be a church, but it could also be any sort of club or group or union or any sort of organization that a person might be a member of. And so this approach is a little bit different because you're directing someone to some organization where they already have an established relationship with. So that's a little bit different than just getting out the phone book and calling every church in your neighborhood asking for help. Okay, update on Lyft. So I wanted to let everybody know that they're doing a great job on that. So far, we've scheduled more rides than any of the other cities participating in the project, and we have not done any marketing yet. Although, yet. So Chris sent out an email this morning regarding Lyft marketing. So just check your inbox for that on some details about the Lyft marketing. And then, but the one thing that we all need to remember, don't forget to put the refer transaction number in the internal memo field of the Lyft portal. Okay, I just got to, I'm going to step back for a moment here because Anna Maria just sent me a message going back to the churches. So she wants to know, what do you do if callers ask for a number and insist that they want it, even if you tell them that the church or agency doesn't help? In that circumstance, as long as we have the number listed in refer, you're able to give it out, just as long as you let them know that, you know, I don't believe that that's a service that they provide. However, I do have their number and I can give it to you. So, you know, we don't want to withhold information from our callers, but we do want to kind of cover our behinds and let them know, like, that as far as we're aware, that's not a service that they are able to provide. Okay, and then, all right. And then next, the Critical ID program at United Way of Greater Toledo. So we've sent over a few referrals recently for folks that were not eligible. And then what ended up happening is the client is assuming that they're going to get the help, they're waiting to get a call back, and then when they're called back, they're told that they're not eligible. So that's pretty frustrating for them because, you know, they're waiting, they're counting on this help, and then they're not even eligible for the program. So just to review the qualifications on that, it's for Lucas County households with any of the following needs: housing, enrollment in school, participation in an employment program, applying for a job, beginning a new job, or applying for daycare or childcare, or for the home energy assistance program. And then here's the key right here. You have to have at least one child under the age of 18 or up to 19 if the child is still in high school, living in the household of the parent who has custody of the child. They will also serve pregnant women starting at 6 months of pregnancy. So this is a key thing. A few folks have sent over referrals to the program for households where there's no children. And then income guidelines, 200% of the federal poverty level. They're looking at the last 30 days of income. At least one member of the family must be a U.S. citizen or a qualified alien, and they must not currently be sanctioned by Lucas County Job and Family Services. For birth certificates, they can only help with Ohio birth certificates, and this is just a once-in-a-lifetime service for each individual who is served. Okay, another reminder here, when agencies are calling and they want to either update their information in the database or they want to be added to the database, please send a transmittal to 211updates@unitedwaycleveland.org rather than transferring the caller to Mike Quigley. So just wanted to remind you guys all, Mike is now working remotely. So he's no longer in the office. So the best way to get connected to him is by sending that transmittal to 211 updates. And then also, if for any reason Mike is not available, he will. He's making sure that one of the research team members is monitoring that email, so those transmittals will be followed up on quickly. Okay. I wanted to take a moment to welcome our new staff members that have joined the team since our last webinar. And so with the Accountable Health Communities, we have Sandy, and with 211, we have Abby. There is more help on the way. So we have requested approval for offers to be made for two more part-time specialists. So that's in the works. So hopefully by this point next month, we'll have a few more new staff announcements for you guys. Okay, and then I wanted to remind everybody about doing the SurveyMonkey for the webinar. Last month was a really poor turnout compared to every other month that we've that I've done these webinars so far. So don't forget to take the survey. It should only take about 2 minutes to complete. And so the link is here, but I also sent it out earlier to you guys a couple days ago when I sent out the agenda for the staff meeting. So if anybody accidentally deleted that email and wants me to resend the link, I'd be happy to do that. Just let me know. All right, and then the last thing, for those of you that don't know, I'm changing my name because Rob and I are getting married next week, Monday, actually. So, so if you see any emails from Molly Black, that is me, for the few of you that did not already know that. Okay, so that is all I've got here for the brief check-ins. Let me see here if Sheree and Jen are ready to begin presenting. I'm going to go on mute for just a moment and make sure that they're good to go. Okay, I apologize for the delay. They're just getting logged in. They were actually at one of the clinical sites doing some work over there, and so they just got back into the office. So I apologize for the delay. Does anybody have any questions about any of the stuff that that any of the brief check-ins? Any questions about that? Any comments, concerns?
Molly, I just wanted to ask, I came in, like, I think when you finished the housekeeping, so I just wanted to make sure that I was signed in.
Okay, Sharon, is it Sharon?
Yes, this is Sharon.
Yes, I got you down there.
Okay, thank you.
Molly, this is Darlene. You mentioned page 3 with the coordinated access. What is the page 3? I just want to make sure I'm doing it, and just in my mind, I can't think of what
sure.
that is. What is page 3?
Let me show you. right here. So the data page, page 3.
Okay.
You click
Yeah.
on
All
there.
right.
And so, I mean, that goes across the board for all of our Tier 2 programs. I know that that our other Tier 2 specialists have expressed similar concerns in the past. So, you know, just be aware. I know sometimes it's a little difficult to remember because you don't get that pop-up reminder as like when you do the end contact.
Okay.
And so I'm sure that's why people sometimes forget this, but just a reminder to just be complete with that. Since I have
one other question too on that.
Oh, sure.
When I pull up the emergency shelter clear and all that stuff, you know, if I'm looking for single family or you know, or single individual or family, whatever, do I always have to save it to the United Way one, or can it be any one of those that do pop up? Because sometimes there's like the, I don't know, Family House or a couple other ones. And I don't always scroll down and pull up the one for United Way and save it there. Sometimes I do, sometimes I don't. I don't know if that's an issue or not, but I thought I'd ask. Since you said to save Emergency Clearinghouse, I wasn't sure which one that one it was exactly. But I know when I pull up for the shelters, multiple ones come up, and as does the one for United Way Coordinated Access.
Okay. Well, with coordinated access, it's going to be a different taxonomy than for shelter. So it's going to be Emergency Shelter Clearinghouse. And so that should be the only thing that's coming up in the Toledo area. The only other thing that's going to come up.
Sometimes I do shelter. I mean, the other one. I'll look for just shelter, and I'll click on them both. Like I'll click on that, and then I'll also click on another one, and then all the private ones, like Rebecca's Haven and some other Cherry Street Mission. Some of those ones will populate too. I don't know if I'm talking all in one breath.
No. Well, you wouldn't be making any referrals to the shelters that directly to the shelters that work with coordinated access, because that's up to our coordinated access team to figure out which shelters that they're eligible for and which ones also have beds available. So you shouldn't really be necessarily talking to your caller and suggesting a specific coordinated access shelter. That's really for them. But you can use in the filters, there's a filter for shelter does their own intake. So you can select that, and then that's going to just pull up. And I don't have any gender here, and I've got both families and single adults selected. And so you can see these specifically are the ones that in the Toledo area that folks can call directly if they meet those eligibility criteria.
Okay.
So we'd really want to offer both. I mean, and the same goes in Cuyahoga County too. You want to make sure that you're offering the coordinated intake at the Cosgrove Center, but also those other few shelters that work outside of the coordinated intake system, because in these areas, shelter space is limited, and a lot of times there's waiting lists to get in. So we want to make sure that we're providing people with information on multiple avenues to accessing emergency shelter.
Hey, Molly, I have a question.
Sure.
What's the length of time that it's taken to get into St. Paul? Do you know?
I don't know. I don't know. And I don't see either Nikki or Sandra on this webinar, so so I don't even have anybody to ask.
Okay.
Oh, hold on. Let me. Tom Peacock wanted to know what is the usual length of time that people have to wait to get into St. Paul's shelter.
It just depends. Supply and demand. There's not a. Yeah.
Okay, so
hey Molly, I got a report I get a report because I'm on the veteran thing on that. Let me pull it up out of my email and tell you what the average days is. So just give me about 2-3 minutes and I might have that answer.
Oh, okay. Yeah, Matt Finley's standing here next to me, and he's saying that the wait for single men isn't usually quite as long. And the reason for that is that there's more beds available for single men in Toledo than there are for single women. So usually it's not quite as long for those guys to get in versus a single female.
Okay.
Okay. All right. Well, I see that that both Jen and Sheree have joined us. So I want to welcome both of them. They are going to be talking to us today about the Accountable Health Communities program, and then giving everyone an update of what's going on with that. Jen, Sheree, which one of you, who?
This is Jen. You can start with me.
Okay, I'm going to send you a invite to share your screen.
Got it. Okay. Can you can hear me? This is working. Okay. So my name is Jen Cons. For those of you that aren't in the office, I'm the Accountable Health Communities Program Manager. Technically work in the Community Impact Department, but work really closely alongside the 211 team to launch this project. So Sheree is here with me, and Matt Finley are working on some technical issues. But I'm going to start talking a little bit about our AHC project overall. So, yeah. Okay. I'm going to pick up the phone so you don't hear the background. So, so AHC is, can I advance my slide? Okay. So AHC is a project that's funded by the Centers for Medicare and Medicaid Services. It's a 5-year project. We're just finishing up our first year, which was a planning year, and then we'll be starting our intervention year in a few weeks. So the goal of the Accountable Health Communities Project is to address social determinants of health. And so this is a little kind of slide on social determinants. So what this is trying to say is that things like tobacco, well, things that we already know, like education, employment, income, family and social support, community, safety, even your housing and transit access and air and water quality, those have a really big impact on your health outcomes. And so those things can make up, so we see social and economic factors can have a 40% impact on your health outcomes. Physical environment can have a 10% impact on your health outcomes, which might be more impactful than your health behaviors or even your ability to access care. So we spend a lot of money in the U.S. on trying to address the quality of care and access to care, which are really important things that we should do, but maybe we should also allocate some time and energy and resources to some of the social determinants, social and economic factors and physical environment factors that impact people's health outcomes. And so that's really the goal of AHC. If we try to address all these social needs, social determinants, can we improve people's health outcomes? Can we change the way they use healthcare? And can we save money in the healthcare system? And so 211 is really a perfect opportunity to do that. We're taking 211 staff, and instead of having them on the phone, we're embedding them in clinical delivery sites and in clinical settings. All right, so I'm going to put this back on speaker. Hello?
Yep, I can hear you.
All right, perfect. Okay. So, like I mentioned, AHC is funded through the Centers for Medicare and Medicaid Services. So Medicare and Medicaid obviously pay for the insurance for people insured with Medicare and Medicaid. A lot of you might know that Medicaid specifically flows through the states, but it's really a federally funded program. So this is a federal initiative. We are one of 32 sites across the country that have been awarded this project. In Ohio, Cincinnati is also an AHC site. We started back in May, and we'll go through, we started in May 2017, and we'll go through April of 2022. So we have a little bit of time left. So who's eligible for AHC? Well, let me say, the first thing that we have to do, the big part of AHC is screening people who are eligible and linking them to services. So some of those things that we'll do once we roll out the intervention is that we'll screen 75,000 patients annually. And if we identify a practice as you're an AHC site, then everybody in that practice who's qualified has to get offered this screening. And then based on the results of that screening, we would identify resources for those patients using the database and refer, and then link people to those social services. And then some people who are identified as high risk, so those are folks that have 2 or more emergency department visits in the past year, we would offer them ongoing navigation, in-person navigation or phone-based navigation, where we would follow that person for a year. So the estimates are that CMS estimates that we should offer to screen about 75,000 people a year. We'll probably get around 50 to 60,000 people that say, yes, I want to do the screening, and that we'll actually interact with. And then of those 50 to 60,000, only 3,000 will opt into that ongoing navigation. So we'll see how those numbers play out, but that's kind of what we're working with. So where are we doing this? Well, it's all based here in Cuyahoga County. We'll be at the Cleveland Clinic at South Point Hospital, which is over in Warrensville, in their emergency department. At Metro Health, we have 3 practices on main campus, so internal medicine, heart and vascular, and labor and delivery. Internal medicine is essentially just primary care, only for adults. And then at the Sisters of Charity Health System, we'll be at St. Vincent Charity in their inpatient psychiatric unit, and that's just an adult psychiatric unit. So folks in this webinar are already very familiar with 211, but I think you can start to see kind of the opportunity here to leverage the amazing infrastructure that exists within 211 and put it in a clinical setting. The second kind of major thing that this project does is we will collect a significant amount of data on what are all the needs that we identified with patients who came in for care, what needs were we able to address, and what needs were we not able to address because the resource doesn't exist in the community, or the resource doesn't exist in a way that the patient needs it or can access it, or it doesn't work for the patient or for the client. And so we'll have a lot of data on these, what we've done and what we haven't been able to do, what are the gaps in our local social service delivery system. And we'll be convening an advisory board of stakeholders, so that'll be our clinical partners, social service providers, Medicaid and the managed care plans, researchers, government folks, foundations, to dig into that report of identified gaps and see how can we do a better job as a community of addressing those gaps. And so we know that we'll find gaps in housing, gaps in transportation, and so how can we come together and do better? So some of those things will take a lot to address, and we hope that we can find a few things that we can address in fairly short order. But over the next 4 years, every year we'll be looking at what are the gaps, how can we respond differently, putting together an action plan on that or a community improvement plan, and then reassessing ourselves. So that it's nice to be able to take kind of a high level approach and try to create more with this project instead of just addressing need, but how do we change the system a little bit? So some of the long-term potential impacts of this project is that we hope to find a model for addressing social determinants, and one that integrates 211 into the healthcare delivery system. So we had, when United Way applied for this project, the way that we envision this working is it's a lot different than how it's played out over time. And so we're really going to continue to tweak and find the best way for us to do this. We might find that the way that CMS mandates us doing it is not really the way that we would do it in an ideal world. So we might come up with a solution that works better for us, that we would continue after the end of the project. There's also this great opportunity to align resources better to address needs. We hope to improve patients to address their health-related social needs and to improve health outcomes. And then we'll also be looking at have we saved any money on behalf of insurers or healthcare systems. So those are kind of the highlights. I'm going to kick it over to Sheree. In order to carry out this project, we've had to do a lot of work on Refer, and when I say we, I really mean Matt Finley. We've had to do a lot of work to bring Refer up to speed in order to capture the data that CMS requires and capture the information that we want to collect, and then put it all together in a way that's somewhat intuitive and efficient for staff to use. So Sheree's going to show you some of the new stuff that we've integrated into Refer. It won't be accessible to you at this point, but just to be able to see kind of something that might be available or might be integrated into your work in the future, and what your colleagues over in the AHC project are doing. So I think Molly's going to shift the screen over to Sheree.
Are there any questions so far before we go into like the demo?
I think it's you.
Is it me?
Yeah.
Okay, I'm sorry. Of course I was around. Okay, can everyone hear me? We're sharing the phone. I'm gonna take that as a yes.
Yep.
Okay. Okay, so there's two things that we have to do, as Jen mentioned. The first thing is when the patients are coming in for their regular clinical visit, they're going to be offered a screening. And that screening was pre-designed by CMS. So we couldn't make changes to that, but right now it's a paper screen that they will complete when they're in the office, and then we will be entering that data into our Refer system. And so what you see on the screen now is just the tool that we'll be using when we're working with those patients. And once we take their paper screen back, then we actually have a data entry person that will enter the information into the actual database. And so right now, this is the actual screening tool that we'll use. And when you start off with that screening, you're just going to select the location where you're receiving that information from. So these are the various sites that we're working in. So if this was internal med, we would just choose that and we would continue. So I'm just showing you a sample of what that looks like. So then we have to input all the information for that patient, all their demographic information. So we have to make something up to do this. So we'll just pretend it's me. So we put all their information into the system, and you have to put all their date of birth and their gender and all their information. This information is coming from their face sheet that we're receiving from the clinical site. So when that patient checks in, they will be printing off a face sheet for us with their demographic information. It'll include their Medicare, Medicaid number, as well as if there's an HICN number, it'll have that as well.
The cool thing about this tool also is that if the patient already exists specifically in AHC, then it'll find that existing record and we'll be able to just add to it rather than creating a duplicate record.
I don't know if it'll let me bypass certain things because I haven't been here. It may require me to put everything in. Let's see. Nope. So I have to fill out everything in order to go past this. But you get the gist. I can't spell, sorry. So once you put their information in, the system, it'll take you to the actual questions that they have to answer.
You put the verified.
I have to put a date. What's the date? 07/11/2000. So the verified basically means that the clinical site has checked to make sure that their insurance is valid insurance. And so we would just be putting the date that we're actually seeing the patient because they will verify their insurance when they come in. I don't know why it's doing that. I was saying it's updated. Okay. Okay. Once you put everything in the screening, it'll take you to the actual questions, and these are the questions that they have to complete to see if they actually can move forward in the screening. Now, in order to participate in the project, they have to have Medicare or Medicaid. They also have to live in Warrensville, Cleveland, or East Cleveland. And then they also have to be a community dwelling patient. So they have to live within the community. So if they're in a nursing home or incarcerated or anything like that, they won't be able to proceed with the screening. And when they get to that point, when they answer that question, they would tell them that they're at the end of their survey. But for the purposes of just showing you what that looks like, you would just say that this is the person that's completing the screening. They ask you how many times you've been in the ER, because remember, if they've been in the ER 2 times or more in the last 12 months, then they could be considered high risk, which means they could qualify for the navigation portion of the service. So we want to know, have they had that? So this, for the sake of this, we'll just say they have not. And then you have to tell where you live. So if you live in any of these locations that's listed on here, a psychiatric unit or assisted living or any nursing home or any of these, then they wouldn't qualify for the service. But we will say that they don't live in any of those, and then hit continue. And then you go on to just complete all of the various questions. And I'm just going to click stuff so you can see what that end result looks like. So they're asking about certain areas of their life. So we want to know about their living situation, which is affecting their housing. We want to know about their transportation. We want to know about their food. We want to know about safety issues in the home. Did I miss someone? Utilities. And utilities. So based on the answers, we're going to determine what services or what resources we provide them with. These are those safety questions. If they do mention that they have safety issues in the home, because we are just connecting them with resources, the navigation specialist won't be, I guess they won't be addressing the safety issues themselves. They would have to involve the clinical site social workers to let them know that there's a safety issue that we have identified, and have them work with that social worker moving forward. Okay. And then, this can be blank. Okay. They don't have to fill this part out. They can leave them blank if they don't want to answer those questions. So at the end, you get the results of the screening. So this tells you everything that they screened positive for, which means these are the areas that they probably would need some type of resource to assist them with the barriers that they may be having. So this information goes to that navigation specialist. Once the data entry person puts this into the system, when we go into refer, we'll be able to see this person with their screening results, and then we would go right into refer to look for the same assessment that you're potentially doing over the phone, but we'd be doing that assessment with that patient face-to-face. I thought that I might, so I do have refer up, so I just want you to see what that looks like in refer. So Matt Finley has been working very hard on creating a client-based service. So when we go into our refer, it looks similar to your refer, except it's going to pop up with the search for the person. So you're on the phones with 211, you're just doing things based on the need, and you're not doing it based on the name. We will actually be inputting the patient demographic information here in the system, and we will search for them by their name to make sure they're not already in the system. So I know that we have been some samples in here, so we'll just kind of look and see if I look for, if I look for Matt Finley, then we see that that patient already exists. And so I could click on that patient's record and select it, and it'll bring up everything that I've done with that patient. It'll have all the questions. So some of the differences that we have in here is we have if I go into the client's record and actually look at their record, let me see. This is where all the demographic information would go into the system. So you're putting, essentially the stuff that came in from the screening will transfer into here, and it'll have all their information. I just didn't select that same chart, but so all the information that you put in the screen, all the demographics, their name and address and phone number and all that will come over to their record. And then there's a couple of questions that do need to be answered to move forward, and those questions are here under the client data. We do want to find out, of course, what language they're communicating in, because we do have a lot of various backgrounds at some of the hospitals, and so if they're not comfortable with English and they may need a different language, maybe Spanish or something else, we want to make sure that we can accommodate their needs. So we do ask them what's their language of preference, as well as what's the best way to communicate with them moving forward, because after they're gone, some of them we will continue to contact with them. So we want to make sure if it's okay for us to call them and leave a message, or if they prefer we email them, or what's our mode of communication. We also want to know who their healthcare provider is, so that we know what services we may be able to incorporate into their plan that we're working with them on. And so the other questions go on how many children are in the household under 18, and this will just help us with finding the various resources that you're already doing for 2-on-1, but it'll help us know what they qualify for, what they don't qualify for. And so we just continue to ask more questions about their household, like what type of income is coming in the house. Do they have benefits? Are they getting child support? Are they working? And then, of course, if there's a house member, I can't see this, if there's a veteran in the house, we ask that, if they've served in the military, and if they're associated with any other agency, because we don't want to duplicate services. We do want to know, are they receiving any services with DCFS or with any other provider, so that we can coordinate services if we do navigate this patient. So those are just some of the things that we would have to ask. The only other difference that we have when working with this patient is under our data forms, when we follow up with a patient, so once they're gone and we do navigation with them and we create an action plan, which I don't have that up. There is an action plan that they create, but when we follow up with that patient, every time that we talk with them, we want to gauge where they are with their goals and their action steps that we create with them. So we will be completing a self-sufficiency screening with them, and then it's just going to kind of evaluate kind of where they are at the time of that call or that follow-up. So it'll evaluate the 5 areas that we talked about: housing, food, transportation, utilities, and personal safety. And we will just kind of ask these questions as we're talking with them to kind of gauge, have they made any progress? Are they still where they are? So that we can kind of show outcomes towards the end of the project. We hope to find that as we're working with that patient, that they are making some progress and their situation is changing for the better, and then we'll be able to gauge that based on their answers every time that we speak with them. I don't know if I have, are there any questions thus far? That's just like a quick overview of some of the differences between the two ReferNet access points or access sites. Nothing? All right, Molly, I don't know if I have anything else unless they have a specific question that they'd like to ask about AHC. We are scheduled to roll out the project, so we're going to be piloting starting next week. We will start piloting at South Point and at St. Vincent Charity, and then on the week of the 23rd, we will pilot the Metro locations. We will be live at all of the locations by August the 1st. So once they start piloting, they will just continue to stay there and then roll right into our live date of August 1st. And that's all I have, unless there's questions. Molly, are you there?
Okay, I'm here. Okay, so
real quick, I got one quick question, real quick. So say you guys are following up with somebody and you guys call and make a phone call. Are you having them call 211, or are you guys having them call the person back at that hospital? If they leave a message.
So when they're assigned to a navigator, they will have a direct contact number for their navigation specialist. All the navigation specialists do have independent cell phones, and they will have business cards. And once they create an action plan with that specialist and they're working directly with them, they will have a phone number to call directly back to that specialist. If they have not been assigned to a specialist yet, and it's just our first time reaching out to those patients, because at South Point we will have some patients that we will have to call from the overnight because we're not there all night, they will get a different number to call in on, like a 1-800 or a local number that Todd is creating to reach an AHC navigation specialist. So none of those calls will come to 211. The only time you will get calls for 211 is if we screen someone and they don't qualify or they have no need. So let's say they have a negative screen and they put that they were fine in every area, but they still have some issues or some concerns or something else, we would refer them back to 211 for services. Or if they're not a community dwelling patient, so if they're in a nursing home and they start the screening and then they find out, oh, they don't qualify for the service, then we will refer them back to 211 to get some additional help for whatever areas they have a need in.
Just as a follow-up, because I just know the population sometimes where they forget and they lose cards and they do that. If they do call 211, is there going to be able to transfer out of in contact to you guys?
We will have the number available. It's like I said, it's a local number, so we'll have to find out from Matt if you would just be able to dial out and just, drop that call in our queue or to our number, because it'll take them to a voicemail if one of us don't pick up.
I'm sure we could get Todd to put that number in the address book and in contact, so that it's easy to find. So that shouldn't be a problem.
I was wondering what how broad-based the interaction is with the locations that they're based in, as far as staff go, to get them connected over to our staff that are there to do this for the people that need the service.
I think I can answer your question. So we're relying on the registration staff. So when folks walk in and check in for their appointments, to get consent from patients. So they'll say, oh, it looks like you're eligible for this. We have a script, actually. Right. Let me see if I can remember the script. United Way and Medicare and Medicaid have a new project to help people address needs like food and housing. You may qualify based on your insurance. Here's a brochure about the program. Let me know if this is something that you'd like to do today. And so the patient will get that brochure, and then they'll decide if they want to opt in or opt out. If they opt in, they'll get the screening tool. This is all before they go back for their visit. And the screening tool, it should take less than 10 minutes for them to complete on their own. And then they'll hand that back to the registration staff before they go in the back. If they don't hand it back to the registration staff, then the medical assistant will collect it when the patient gets in the room. So we are relying on the clinical staff at the very front end to get that consent, to record it, and then to get the patient the screening tool. That looks a little bit different in the emergency department and a little bit different in the psychiatric unit, but in all those places, it's the clinical site staff that we rely on for that process. And then Metro specifically has really made changes in their electronic medical record system so that patients who are eligible for AHC, when they check in, there's a hard stop. The registrar can't move forward unless they opt the patient in or out. So what we've been doing over the past 2 months, I'd say, is going to all the sites and meeting with the providers, meeting with all the clinical staff, so the medical assistants, the nurses, the registration staff, the social workers, and just letting them know about the project and kind of engaging them in the process. And then really over the past few weeks going in and specifically with the registration staff doing training on the process that they'll have to complete. And they've been really engaged. So we identified practices that were kind of eager to do this and really interested in the product and saw it as a benefit for their patients. And so we've had this kind of top-down buy-in that, yeah, we want to do this and we want to make it work. And so the staff have picked up on that and for the most part been really willing to work with us and take on the role. So we were just there. We were just on the show this morning.
That's where we're coming from.
Yeah, training staff. And then we'll go back this afternoon.
I have two questions. Number one, how are you handling the language issues when they do not speak English or are not comfortable with English? And my second question is, I'm concerned about they're receiving a paper survey, but the literacy level of some of these people is not going to probably be conducive to them completing that survey. And how do you handle that?
Yeah. So for the language, we have, depending on the need, we have 9 different languages that the screen can be translated into, that we have access to, that we can print off in a different language. We do have 2 bilingual staff members that are on the AHC as navigators that will be at Metro Health for Spanish specifically, because we spoke with all of the clinical sites to find out, what languages specifically they had, I guess, their population utilized the most. And so Spanish was high, and so was Arabic and I think Swahili at Metro. So we did hire 2 bilingual staff, and so we have access to their interpreters. They're on site, and then we have the screening tool available in 9 different languages. So we'll be able to accommodate their needs as far as the language is concerned. For the language line, and the hospital has a language line as well. For the literacy-based issue, what we've said is if there is a patient that cannot read or need some assistance with the screening, they will just hold on to their screening until they get to a navigator. So they will go through their clinical visit and still have their screening with them. And when they get to the navigator would have to walk through the screening questions with that patient. On the psychiatric unit, we're doing that already. The navigator that is on site is doing the screening with the patient. So they won't get the screening tool by paper. She'll be asking the questions right there in front of them, completing the screening, then going right into the assessment with those patients.
At St. V's, are you in the psychiatric emergency room or the inpatient psychiatric unit?
We're in the inpatient psychiatric unit. So they have 3 floors, the acute, the geriatric, and the adult unit, and we're servicing all 3 of the units, not the ER. And in that unit, we're working very closely with the social workers on that unit. So they have 6 social workers that service those, the psychiatric units. And so we've trained those social workers, and we're working in collaboration with the social workers. They will complete their psychosocial assessment, and then we will work with them on completing the screening and and doing our assessment and getting them the resources before they are discharged from the unit. Any other questions?
So when we have told hospitals about this, when we've gone out and on the road and talked to the sites, everybody says, well, what if patients don't qualify? How do we get them the resources? And so we've definitely been talking about 211 and the ability for folks, anybody can call 211, as you all know. And so there's been a lot of interest.
Yeah, so we will have RAT cards and different things that we will be able to hand to patients who may not qualify for this particular service. Because I'm sure there will be people who will see other patients filling out a questionnaire, and they would want to know why they don't have that paper. So if they don't qualify necessarily for AHC, we will provide them with a way to connect with 211 directly to get assistance for whatever they need.
Especially uninsured patients. Yeah. All right, you guys ask great questions.
All right, anything else?
All right, does anybody have questions about anything, even if it doesn't have to do with AHC, any of the brief check-ins that we went over earlier, any comments, anything?
I want to just congratulate you for getting that all done so quickly and so effectively, it sounds like.
We're excited to see it unfold.
All right. Well, I wanted to thank everybody for attending the webinar and for the good questions that you had for Jen and Sheree. And so I just wanted to remind you all again, please complete the SurveyMonkey that I sent out earlier. a few days ago. If for any reason you accidentally deleted that email, just let me know and I will resend it to you. And then we'll go ahead and end now then. Thanks, everybody.
Thanks and congratulations.
Oh, thank you.
Congratulations.
Oh, thank you.
Thank you and congratulations.
All right, thanks.